Another issue is lower lateral crus recurvature. A lot of patients come in with this. If you bind those domes, you're going to risk causing these to come in further and causing airway obstruction. So what I'll do is I'll take a piece of cartilage and I'll place it just over the most lateral portion of the lower lateral cartilage to keep that extended. Now I used to place this always over the lower lateral cartilage. Now I'm starting to place it under. But you can do it either way. So this is what it looks like. I place that cartilage out there. It goes over the piriform aperture, but it keeps that from extending back into the airway. So here's a patient, recurvature of the lower lateral cartilages. I did a domal binding suture. Now in her, if I did a domal binding suture and I didn't concern myself with the recurvature of the lower lateral cartilage, she'd have trouble breathing because I know this would recurve back in. But instead I took a piece of cartilage and I extended it out here, going under or over the lower lateral cartilage, most lateral portion, extending out over the piriform aperture, and it keeps that wide open. Her external valve's wide open, and she's actually going to breathe better and look better. She has a more triangular appearance to her nasal tip. Another area in the tip I think you have to be careful for is what I call the Bermuda Triangle. I'm not sure if you guys know about the Bermuda Triangle over there down under, but here,
oh yeah,
you know about the Bermuda Triangle. Okay, it's a part of our hemisphere where you worry about problems, and I call this the Bermuda Triangle, the perfect storm. Overprojected nose, thin skin, and prominent lower lateral cartilages leave this area, the soft tissue triangle, often overlooked. Too often overlooked. And in a rhinoplasty, if that portion is not attended to, especially in a closed nose, you get this. Telltale sign of surgery. She's had rhinoplasty. Everyone knows she's had rhinoplasty. Something about her doesn't look right. This area wasn't attended to. Whoever did her surgery did domal binding suture, hump reduction, but didn't think about this area, and she's got retraction. And I started to see in my own patients. This is a patient I did in my first few years in practice, closed nose. I was happy, but she started to get retraction. And I started to see a lot of this retraction in my patients. It took about 5 years before I realized that many of my patients were getting retraction right here. Why was it retracting up? I think I was doing domal binding sutures. I was bringing the lower lateral cartilage up, and the cartilage and the margin was being scarred up, was coming up with it. So I had to do something to increase the support to that soft tissue triangle. So what I started doing, also through a closed approach, is after I put in that soft tissue cephalic margin graft that I showed you, I took soft cartilage, usually also cartilage from the cephalic margin, and I secure it to the caudal margin of the lower lateral cartilage, just like that, all the way up into the tip, right there to the intermediate cartilage, and I secured it in place like that. And this is a diagram showing what it's like in vivo. And I use the 30 gauge needle to keep it in place as I suture it in place with 6/0 PDS suture, and it will keep support in that soft tissue triangle. So just like this, that soft tissue triangle stays nice and caudal like it should, instead of retracting up. I would say about 75% of my patients get this now routinely, especially in the closed approach. But even in the open approach, I'll do this because I want to keep that margin in place. If you don't put this in place, I think the skin starts to retract up over time, and you start to see the telltale signs of surgery, and they have excess columella show. So placing that cartilage in place makes it look much more appropriate. Same thing here. You can see that soft tissue triangle, which is pretty prominent here, is well supported here by a little tiny soft graft that goes right there. Keeps it in place. Sometimes you need alar sidewall support. If you have really thin walls like this, you got to put in a cartilage graft. So what I'll do is I'll use these alar rim grafts. These are really easy to put in, and it's made a big difference in my rhinoplasties. I call them fender grafts. But what I do is I place them in through a precise pocket. I make a tiny incision at the base of the columella, or the base of the ala, after putting local anesthetic, and I dissect up with a little Stevens scissors all the way up to the tip, and then back down to the alar base, and then I slide in the graft into a precise pocket. And it keeps this area very well supported. It prevents it from retracting, and it also allows that external valve to stay open so they can breathe better. And you can see pretty easily how that graft is sitting in there. I have another graft sitting in there. And that keeps that sidewall supported. Whereas you can see how that could buckle in if you don't have that graft in place. So graft in place is keeping that alar wall supported. Afterwards, you can see the strength of that alar wall by keeping that graft in place. How about the skeletonized tip? This is a patient that was done by someone else. Asked me for help because she thought her tip graft was too obvious. She had tip graft placed in many years ago. So what I'll do now is I'll take crushed cartilage and I just place it right in there just like that. And it sits right on top of the tip. Oftentimes I'll use that postauricular fascia that I showed you from the behind the ear, and I'll slide that in there. But I may use crushed cartilage also and place it over the tip. So here's a patient who came to me and said, "Doctor, I want to look better." This is, beforehand. And in the past, I might say, okay, if I was going to do a closed approach, do a hump reduction, cephalic margin trim, maybe a complete transfixion make her look better. But I don't do that anymore. Now I look at her and say, okay, well, what am I going to do that I learned from the open approach that I can do in the closed approach to give her a better result, but yet still a stable nose that's not going to collapse 5 years later? So, in her, I did all these things. I did a spider graft, cephalic margin trim graft, soft tissue triangle grafts, alar room grafts, crushed cartilage to the nasal tip. I even put a radix graft in her. And afterwards, she looks like this. It's a year later. I think she looks a lot better, but she's got multiple grafts in here. She's got a graft up here. She's got grafting in here. She's got grafting in here. She's got grafting in here. All kinds of grafts done through a closed approach. But she looked better 1 to 2 weeks after surgery. So, an open approach may be necessary. And I think it is a good idea a million times. But I think there's also things that you learn from the open approach that can be used in a closed approach so that you can gain the benefits of a closed approach without having to do the open approach. And I think this way you assure better predictability and outcomes if you do it this way. So it's just a way of taking techniques we learned from the open to use into the closed.